And you all can hear me fine?
We do.
Okay, very good. So let's just get started. By request, we'll be talking about congenital primary megaureters. And the objectives this morning, I just wanted to outline the diagnostic approach to primary megaureters and just classify the various types and how we work through that classification system and how we presently manage primary megaureters. Okay, so megaureter just is a dilated ureter, irrespective of cause, and how we typically define them is any ureter that is larger than 7 millimeters on ultrasound. For this talk, we're going to confine it to primary megaureters, which are conditions intrinsic to the ureter itself, or what we think of as problems in or at the ureterovesical junction. There are secondary megaureters that are related to bladder or urethral pathology, which is a whole another bag of worms, so to speak. The conditions dealing with
Excuse me, it looks like the slides are not changing.
Katie, can you see where I am? Is it moving? It says megaureter. Can you see any of that stuff?
Yes, I see the first slide.
You still just see the first. He still just sees the first slide. Okay, let me back up for a second and see. Do you see any of?
I can see the left hand of the screen where it shows the upcoming slides, but it looks like you're on slide number 1.
Okay, on my screen, it's showing, okay, on my screen, it's showing, okay. Anything?
If you try slideshow, maybe?
Yeah, that's what I'm on my computer.
Or maybe are there 2 windows open? I wonder if it's showing.
Let's see, because I have a split screen here. Let me, hold on a minute. Okay, let's see. All right, did that do anything?
No, I think now we see objectives.
Now it's okay.
Okay, all right, can you see that? Okay. Mm-hmm. Are you seeing megaureter? Dilated irrespective. Do you see this now or no?
Yeah, I see.
Okay, it's working now. Okay. I think, yeah, okay.
Lauren says she's just trying to get her audio to work. I guess she can't hear. So.
All right. So primary megaureter being conditions intrinsic to the ureter itself or the ureterovesical junction, and secondary megaureters being a broader topic related to bladder and urethral pathology. Particularly, we think of neurogenic bladder and cases of posterior urethral valves when we talk about secondary megaureter. And for the confines of this talk, we're going to stick to primary megaureter. So primary megaureter is typically diagnosed on ultrasound, and this is just a classic image. You can see the bladder and then the ureter longitudinally going into the bladder, the ureter being dilated and then coming down to just a smaller caliber as it enters into the bladder. And so typically that's typically what we see with primary megaureter. And here's just another depiction of that, including now the kidney, where we see the ureter being dilated, and it's dilated typically at its most distal points, and that degree of dilatation may not translate into the intrarenal collecting system. So we categorize megaureters based on the presence or absence of reflux or obstruction. And we have 4 classic categories: obstructed megaureters, refluxing megaureters, non-obstructing and non-refluxing megaureters, and then finally refluxing megaureters with obstruction. So why do megaureters even develop? We really don't know. That pathogenesis is largely uncertain, but we'd like to think that with obstructed megaureters, that there is some abnormality within the muscular development of the distal portion of the ureter. And this can be, this happens around 20 weeks of gestation. So such that we have an adynamic segment at the terminal end of the ureter at the ureterovesical junction. And again, we see this upstream dilatation with functional obstruction as the urine is static within that dilated ureter. With refluxing megaureters, it's thought that there is some abnormal ureterovesical tunnel that allows the urine to reflux up the ureter during bladder filling and also during voiding, which is most common when the bladder pressure is the highest. So when we think about, and as you said, in Rwanda, megaureters aren't that common. But when we look at megaureters in total, they are the second most common cause of hydronephrosis in the newborn, with UPJ obstructions being the first, the most common of the pathologic causes, with megaureters representing, depending on what study you look at, anywhere from 10% to 23% of antenatally detected hydronephrosis. It's more common in boys than girls, more common on the left side than the right, and about 1/4 of the cases will be bilateral. The natural history of megaureters is that they typically have a benign course and they resolve spontaneously within the first few years of life. But our job as pediatric urologists and urologists in general is trying to figure out which of these children will go on and require intervention. And we'll get into that as we move further along here. But when we take megaureters, again, just the textbook definition, any ureter that's greater than 7 millimeters on ultrasound. But what we do know is that those ureters that are typically a centimeter or less, they rarely require surgery. They typically resolve in time. But those that are greater than a centimeter, about 1/4 of those will go on and require surgery. And that's where we come in, trying to figure out the art of medicine, when, to operate on these children. So this was a study done in Germany where they looked and they followed 49 children with 56 primary obstructive megaureters. And they took a conservative approach, which was serial imaging with ultrasound and continuous antibiotic prophylaxis. And what they found is about 80% of the ureters regress spontaneously. And the long-term renal outcome for most of these children was really a good outcome, except for those cases who already had some type of renal abnormality, such as hypoplasia or dysplasia from cystic disease. Again, this is another study where they evaluated the outcome of non-operative management of primary non-refluxing megaureters, and they had 60 children with 74 primary megaureters. And again, about 1/4 of these children went on to surgery. So I think the common theme here is that most of these kids will not go on to surgery, but our job as urologists is figuring out who goes on to surgery and at what point can we be confident in saying that this child no longer requires follow-up. So the clinical presentation for most children in the US. It's antenatal, we detect these antenatally, and they're asymptomatic, with hydronephrosis being the most common abnormality in the US that's actually picked up on prenatal ultrasonography. So most of these kids will be asymptomatic. I have had children who had normal prenatal ultrasonography workups and presented as older children with urinary tract infection, hematuria, pain, or abdominal mass. And these are typically obstructed. And there are papers that are written that these children can present in essentially Diedel's crisis, which we've classically associated with UPJ obstruction. We can also see this with UVJ obstruction, with flank pain, hematuria, and nausea and vomiting. And also presenting as older children with stone formation. And folks that present older are usually surgical candidates, because again, they're symptomatic at this point. So they typically will go on to surgical intervention. So as I said, most of these cases are identified prenatally. And so postnatally, we confirm the diagnosis with a renal ultrasound and place these children on continuous antibiotic prophylaxis, because they are at high risk of development of urinary tract infection due to the urinary stasis. We prophylax with amoxicillin, usually 12 to 25 milligrams per kilo once a day until the child is 2 months of age. And then once the fetal liver has matured, we switch to Bactrim prophylaxis at 2 milligrams per kilo once a day. Amoxicillin has to be refilled at the pharmacy every couple of weeks, and so that can be cumbersome for some families. But Bactrim is refilled once a month, and for us, these are both considered generic medications and are not very expensive, it is typically recommended that we do continuous antibiotic prophylaxis until the child is toilet trained or there is resolution of the megaureter. So to go back to the initial evaluation, again, prenatal ultrasonography detected, then postnatally doing an ultrasound to confirm the diagnostic findings. And here, again, the classic pictures of what you see here with the bladder, the dilated ureter behind the bladder, and then here in another view, again, the dilated ureter running behind the bladder. And we also will typically do a voiding cystourethrogram to detect if there's any reflux, and also to detect if there's any urethral obstruction, because then that will then put us into that category of most likely of secondary megaureter. So this is a classic picture of a VCUG in a female patient, catheter going in, filling up the bladder, and you can see the reflux and the massively dilated ureters on both sides. Renal scan also can be part of this evaluation, the diuretic renogram. We typically would not perform this study until after the child is at least 2 months of age, but so that the tubules are mature enough to handle the tracer. We typically use MAG3. And this study for me and my own practice is really not, if I do an early renal scan, it really is kind of we use it as a baseline to document the baseline function, knowing that in infants, just because of how the maturity of the tubules, that this may not be the best test for obstruction very early on, but it can tell us something about the split function. And this is a normal renal scan here, with, in the sense that the split function is good, 51%, 49% on the megaureter side. And the kidney is draining. So we would, with the renal scan like this, just recommend continued follow-up and follow-up being with routine ultrasonography. So how do we decide, when to operate versus not? And for me, there's some hard and fast surgical indications in symptomatic patients with recurrent urinary tract infections or pain. If you see progressive dilatation on your renal ultrasound with thinning of the renal cortex or declining renal function, if the differential function is less than 40%, or if you get serial renal scans, there is a difference of greater than 5% on sequential functional studies, then the recommendation would be for surgical intervention. So this is just an intraoperative picture of a primary megaureter. As you can see, this terminal portion being stenotic and the tortuous and dilated portions more proximally to this, and this obviously being the problem. And so for definitive surgery, the stenotic distal portion that we talked about is excised, the ureter is straightened, and typically we recommend tapering you can taper the ureter either excisionally or with imbrication, and I'll show some pictures of that later. Depending on the age of the child, usually in infants and smaller and younger children prior to toilet training, would recommend probably tapering that over an 8 French catheter. With an older child that is toilet trainer, school age children, probably over a 10 French catheter. And you want to taper the ureter so that you get you can put it in the bladder and put it in the bladder such that you can create a tunnel that won't be refluxing. So that's why we choose those 8 and 10 French catheters, because typically you can get the ureter small enough that you can then create an anti-refluxing tunnel. Their approaches, both their open approaches, laparoscopic approaches, and robotic approaches. I still do all these as open cases. I actually don't do laparoscopic or robotic approaches in my own practice. For me, an open tapered ureteral reimplant is an overnight stay in the hospital, and kids tolerate it well, and it's an hour and a half to 2 hour surgery. So I still actually do them all open. My partner here in practice, she does them robotically. From a success standpoint, I still, in my hands, still I'm over 90% successful. So I still believe in the open approach. But if somebody wants them robotically, then certainly I'll let her do them. So I temporarily do some form of post-operative stenting, whether it's a stent that comes out the skin that stays in a week, or a double J stent that stays in for 4 weeks. The only issue I think with longer term stenting is for me, then the patient has to get a second operation to retrieve the stent. But if you do a temporary stent that you bring out the skin, then typically you can take that out in the office a week later. And that's nice for the patient not having to undergo general anesthesia again. And I don't like stents on strings in children. I think they get pulled out. So I liked the idea of just doing a cutaneous stent. So talking about the different techniques, there are 2 techniques, one being the plication technique, where the ureter is folded or imbricated again over that 8 or 10 French tube. So to do this, I usually take Alice clamps and mark the redundancy with those clamps. And then I remove the clamps and then fold those edges over, just using using Limbert stitches where the Alice clamps have left the impression. And I use just an interrupted 5/0 or 6/0 monofilament suture. And so effectively, then when you've imbricated, you defunctionalize that folded segment. The good thing about an imbrication technique is that you preserve the blood supply. You preserve all the blood supply to the ureteral walls that's left intact. And I think it's a good technique when ureters are less than 2 centimeters. But when they get much bigger than that, the ureters can be extremely bulky, and then trying to reimplant that into the bladder can be somewhat difficult. So that again, an option, but when the ureters are really bulky, I think excisional tapering tends to work best. And this is an example of an excisional taper using hindering clamps. I don't think you need hindering clamps to do it. I think Babcocks or Alice's are usually fine, but described by the esteemed Dr. Hendren several years ago. And so instead of folding or imbricating the redundant tissue, you excise it over the less vascular portion. And I usually use a 5-0 or 6-0 Vicryl or monocryl as a running suture over the excisional part that I've excised. But the most distal part of the anastomosis, I typically interrupt just in case I need to trim any ureter. That just allows for a better fit. And then doing that nice submucosal tunnel to prevent reflux. And so that would be, the ideal. This would be, ideal. We've planned it. This child has had progressive dilatation or decline in function, and then we plan for and their bladder is big enough. Typically, I reserve reimplantation for a child that's a year old or a year or older. But what if I have a smaller child, an infant, who has a megaureter that is problematic, causing problems with infection, or we see progressive dilatation? Then often I will then temporize, and I'm going to skip. I'm going to come back, but then oftentimes I will temporize with just a cutaneous ureterostomy, where I make an inguinal incision, go down, find the obliterated, and find the ureter running underneath. And depending on the situation, I will either do a loop cutaneous ureterostomy or an cutaneous ureterostomy to decompress the system. So it just depends on the age of the child and what needs to be done. So now going back to surgical outcomes for primary megaureter, the success rate is over 90%. Typically, the complications that we see early, you could have obstruction, and that most oftentimes is due to postoperative edema, but stenting usually helps with that. So I tend to stent all my anastomoses. Late obstruction would be because you have an ischemic stricture, and I really don't think you can get around doing a redo reconstruction. With reflux, depending on the grade, you could observe it, treat, or you could treat with deflux, or you could do a redo reimplant. Persistent dilatation, if it's not obstructive and the system is draining well, then observation is appropriate. There is, in the last decade or so, folks have been talking about doing endoscopic dilatation with a ureteral catheter or high pressure balloon dilatation, where you put a ureteral dilating balloon and dilate it up until the waste is gone, and usually leaving a stent in anywhere from 2 to 6 months. The success rate has been about 70 to 80%. I, in my own practice, do not do this. Just because the success rate is lower, and it to me, the complications, I'm not willing to risk the complications from it, where you're dilating and you end up with the ureteral injury, and then you have to then go ahead and do an emergent reimplant while you're there, or complications of stent migration, or with long-term stenting, you worry about stone formation or even just recurrent infection with the stent in place. Again, back to if we had an infant that needed prompt decompression, we would do a temporizing surgery in the form of a cutaneous ureterostomy typically because one, the bladder usually isn't large enough to do a non-reflux and anastomosis. Cutaneous ureterostomy being the procedure of choice. Nephrostomy tubes, certainly you could put those in as a temporizing maneuver, but they're typically difficult to maintain in infants. They don't have much fat, so they don't stay in well, and they move around a lot and tend to pull things out on accident. So, but certainly if you're in a pinch and you need it to do a nephrostomy tube, that's certainly a viable option, but really not a long-term solution. With the cutaneous ureterostomy, as I showed you before, this is typically how the standard approach. And I usually leave those in place until one, the infant has grown enough that the bladder is large enough to make ureteral reimplant more successful, and that the child overall is doing well from an infection standpoint, and that the dilatation has significantly improved. So are there any questions about any of the information that I just went over? Before, I just have a couple of cases that I wanted to go over that I've been able to take care of in the past year, but I wanted to know if you all had any questions before we moved on. Okay. So case number one is a 5-week-old female who presented with febrile urinary tract infection. And as part of that diagnostic workup for febrile urinary tract infection, we performed a renal ultrasound and a voiding cystourethrogram. And these are a couple of representative images initially here from the renal ultrasound. As you can see, this is the bladder here. There's no intravesical pathology, but then we do see a dilated ureter behind the bladder. And then when we move up to the renal portion of the ultrasound, we see a dilated upper pole with a dilated ureteral segment coming off of that and a more normal lower pole. The voiding cystourethrogram demonstrated a high-grade vesico-ureteral reflux with a somewhat ectopic megaureter with that was again refluxing. To temporize this patient, she had to be, she was placed on continuous antibiotic prophylaxis, but continued to have breakthrough urinary tract infections, and she had to be temporized with an incutaneous ureterostomy with the ureter taken down to close to its origin of its ectopic insertion and divided, and brought up an end ureterostomy to temporize the patient. And that was left in place for the first year of life. And then after that, the patient underwent ureteral reimplantation. She's got some non-specific, so these are now after ureteral reimplant. Here you see there's no longer, she underwent cutaneous ureterostomy, then large enough, then the definitive operation, ureteral reimplantation, and actually a end to side ureteral ureterostomy, because the lower pole ureter implanted nicely into the bladder, and we already knew that it didn't reflux, and just reimplanted the dilated upper pole ureter into that lower pole segment. So now you see there's no longer a dilated segment behind the bladder, and much improved upper pole hydronephrosis, and the patient is now been definitively treated and off antibiotics and doing well, and the stent removed. The next case is a male baby who was identified prenatally, again with a similar picture, but again, no infection, dilated megaureter behind the bladder, the ultrasound renal portion demonstrating a dilated upper pole, and a normal lower pole underwent a voiding cystourethrogram with no evidence of reflux and no evidence of urethral pathology. So a primary megaureter. And then over time, we did do a renal scan, which demonstrated preserved function with the um, left kidney being 51% and the right kidney with the obstructed, with the megaureter being 49% function. So we have preserved function, but as you can see, the T1 half is slow. But again, this is an infant with preserved function. So the initial management was observation. But as time went on, there was progressive dilatation in the upper pole segment. So the plan then was treatment, and the patient underwent a tapered ureteral reimplant. And so what you see now, you don't see the dilated segment behind the bladder anymore. And again, here is the intrarenal portion. Still some dilatation in these early post-op pictures, but you no longer see that dilated ureter behind the bladder or heading down to the bladder. So I guess for me, deciding when to operate on these children, and for me, it is with really, if I see a progression in the dilatation or a decline in function, or there is some symptomatology with febrile urinary tract infection, or in older children that there's pain associated with the pathology that we see. So thank you all for your attention this morning and this afternoon for you all, but I'm happy to entertain any questions or anything like that at this point.
Thanks, Dr. Monroe.
Thank you. Thank you.
I had some questions emailed to me and I just sent them in the chat, but the first one is, please describe how you downsize or taper the megaureter.
Okay, all right. So typically I do an excisional taper, and when I do these, and I use a red Robnell catheter or red rubber catheter because they don't have balloons on them. And in infants and younger children, I do an intravesical approach, circumscribe the ureter, free the ureteral attachments up until the ureter's free, relatively free up into the retroperitoneal space. The stenotic segment, I excise the stenotic segment, pass the 8 French red Robnell up the ureter, and then use Alice clamps to snugly fit along the ureter, the portion that I'm going to excise. And I typically do an excisional taper along the least vascular portion of the ureter, excise it, and then I use 5-0 Vicryl and do a running closure, and I just do a 1-layer closure. And the most distal portion of the anastomosis, I will interrupt it just in case I need to trim. And I do usually a Cohen type ureteral reimplant, where I create a tunnel that is 5 times in length as the diameter of the ureter, and I go trans-trigonal, because in younger children, that's usually the only way you can get enough length. And do just close up the hiatus. I use the same entry point, but I use it because it's a megaureter. Typically that hiatus is somewhat enlarged. I use a couple of interrupted Vicryls to taper down the hiatus. And then again, run the ureter submucosally in a Cohen fashion, trans-trigonally, and then mature it with Vicryl to the cystotomy site, the site. And then as far as stenting, again, you can use a double J stent and leave that in, but it just commits the patient to another procedure. I like using just a open-ended ureteral catheter and securing that with a chromic within the bladder, and then bringing that out the bladder through a separate stab incision and securing that to the skin with a non-absorbable suture. And then closing the bladder, I close the bladder up in a couple of layers with dissolvable suture. Typically I use 3-O-Vicryl for that, and drain a Foley catheter drainage for drainage overnight. I typically remove the catheter the next morning and allow the patient to start voiding, and then bring them back to clinic and remove the open-ended catheter about a week later, just clipping that stitch on the skin, and then just usually that chromic or whatever in the bladder, it usually is pretty much dissolved, or you can, it comes out pretty easily, and taking that out in the office a week or so later. But that's usually what I like to do. I like excisional tapers over imbricating, because to me, imbricating, it can be rather bulky unless if you've done a cutaneous ureterostomy on the patient and the ureter is fairly small, then I think you can easily imbricate. And then in some cases, you don't even have to taper at that point. If you've done a cutaneous ureterostomy and the ureter comes down to size and you can get a reasonable tunnel, you may not even have to taper. But I oftentimes find that excisional tapers work better for me. So so where should I look for the questions?
There's only,
Okay, I see. Okay, okay, please send me these questions. Okay, I'm happy. No, I like to do an excisional taper. How do you assess well, that's a difficult question. You really, for me, I try to just look, and I literally use loop magnification, and I'm just looking at the vasculature, trying to determine where there are more vessels versus not. And I try to go where it's relatively avascular. But that is a risk of excisional tapering, as he's almost that you could cause an iatrogenic stricture because the ureter is devascularized, or it does not peristalse effectively because it is devascularized. So you do raise some excellent points with your questions. But I am more happy with excisional tapering than folding. Folding tends to me just be so bulky. So I like to excise. So yeah. Okay. Are there other questions?
Can I ask a question?
Please.
What the last megaureter member was, I think, total duplication with total duplex with obviously primary megaureter. No, was a partial duplication with primary megaureter. I think, if I recall, several years back, I think there was one of the colleagues from US. We did, I think, ureterostomy.
Mm-hmm.
You talked about that in your presentation.
Mm-hmm.
The point I want to stress here, about the approach,
Mm-hmm.
is from transvesical approach, right? And don't you think it's quite risky to anastomose the megaureter to the normal ureter in that portion of the bladder?
Right. So yeah.
Because of poor vascularization.
Mhm.
What do you think about this? Is it
Right.
something
So,
good?
right. And I normally, so in both of these cases, even though they were both duplex systems, one of them I elected to do a um the UU, and it was based on ureteric length. So it is risky. You're right. You do run the risk of damaging the good ureter. You do, right? And I think that's anytime we do a UU, we always run the risk of damaging the good ureter, so that we counsel the families appropriately. But in that particular case, I didn't have a lot of ureteric length after her cutaneous ureterostomy. Just once we did the end ureterostomy and just healthy ureter. And for me, for that particular case, I did the UU. But you're absolutely right. To me, it is somewhat riskier to that good ureter that now you're plugging, so quote unquote, a bad ureter into it. You're absolutely right. And on the second case, I actually did not do um, a, um, a UU. I actually did a common sheath. I brought them both in, and then I tapered the bigger ureter, and I did a common sheath tapered ureteral reimplant. But you raise an excellent point, and that is always a risk. And um, it just depends on each child is different, and it just depends on what they present. In that first case, I didn't have a lot of ureteric length, and the best approach for her would have been, I said, I kind of weighed my options and said, the risk to the healthy ureter, or do I put tension on to do a reimplant of the bad ureter with not enough length. I was going to have to move the good ureter anyway. So I really didn't have a lot of options, but you're right. I'm not a big advocate of doing the UU because of that. That is a real risk.
So,
but I think if you feel like you can safely do it, then do it. What is your experience? Do you do the UU often, or are you most oftentimes? I'm sorry, someone's mowing grass behind me, and I'm sorry for that noise because I think it's probably transmitting.
no, actually we have very limited experience on megaureter.
I can't hear.
For especially, I think you say, I mean, in the literature, it's clear that the second common cause of the second cause of hydronephrosis in children. But here, of course, hydronephrosis, most cases of hydronephrosis in children is, of course, the UPGO.
Right.
But we have quite a number of posterior urethral valves. We have quite a number of duplex kidneys with ureterocele, but primary megaureter. So my colleagues can intervene and tell us about their experience. We do not see megaureter as the second most common cause of hydronephrosis in I mean a primary megaureter doesn't seem here to be the second cause of.
Well, you don't see that often. So what ages are you seeing most of your patients? When are your patients presenting? Are you seeing them like prenatally, or is it later in life, you think, with your megaureters?
No, we see them after, we see some, very few prenatally, but the great majority are seen actually after birth. The great majority are seen after birth. But Florence, are you on? Emmanuel?
Yes, sir.
So can you talk about your experience? Because Florence, see many of these kids. primary megaureters?
I do not see them often. And the most cases that I see are they have megaureter but not primary. They are secondary to either urethral or reflex cells. So not primary.
It's very interesting.
So, so which incision do I do for a one-side approach? So if I've done a cutaneous ureterostomy already, I'll go back through that inguinal incision and just use that incision. If I am doing it, even if I'm going to do a reimplant, you can still have reasonable access to the bladder. That way, but if it's primary and I've not done and if I'm doing an intravesical reimplant, I will just do it through a fan and steel. And the fan and steel is about a 3 centimeter incision that I use in infants and children to do a tapered ureteral reimplant. And like I said, I do them intravesically through about a 3 centimeter incision.
Now, another thing, here we do not have renal scans.
Right.
So if you were in our situation here, how do you safely decide on surgical indication, surgical management?
So I would think so, because function won't be, renal scan, since it's not readily available, that's not, we won't do function. But I would think if recurrent urinary tract infection or progressive hydronephrosis, those would be good indications to do an operation. And not everyone gets a renal scan. As in my first patient, as I showed you, that patient she never got a renal scan. Typically, because renal scan requires, depending on the institution, it can require general anesthesia. And if we can save a child an anesthetic, then I'm an advocate for that. And typically I will do an ultrasound and VCUG to make the diagnosis and then follow with sequential ultrasound. And then when that ultrasound changes, meaning that it's making a change for the worse, then you have an indication with progressive dilatation to repair the megaureter. So I would think just ultrasound surveillance would be appropriate. And then depending on, the availability of that, then coming up with a surveillance schedule, whether it be a 3-month or 6-month or annual ultrasound. I tend to ultrasound more in the earlier phases of life, every 3 to 6 months. Then when a child gets older, then if I'm comfortable and things are stable, then I would move to an annual ultrasound. But I think ultrasound is a great way to survey these and then make the decision, because with renal scan, even if you do an early renal scan, you're really a lot of times you're not operating on that, you're just documenting the function, right? And then if you want to do so, that child that had the renal scan that showed that yes, this was an obstructive system, we followed him with ultrasound. And then as his ultrasound progressively worsened, we use that as an indication to repair the megaureter. Because I'm not because for renal scan, again, depending on where you are, if it is available, it can require general anesthesia. And I'm not an advocate of repeated general anesthetics especially if they're not going to change my management. And ultrasounds are cheaper and they give us the information that we need. And once we do the operation, we're going to follow them with ultrasound anyway, post-op, to see if the operation was successful. So I'm a big advocate of using ultrasound. I do like to get a baseline VCUG so I know if I have reflux or not.
Good. So if nobody else is asking questions, let me ask another one. Of course, you propose the cutaneous ureterostomy if the bladder capacity is still small. How do you decide that the bladder capacity now is able to accept the reimplantation?
So typically, if a child is growing appropriately, usually at about a year of age, when you look at reimplantation, if the child can, if you can get them up to a year of age where the bladder is growing, and most kids are, right? They should be growing along the normal benchmarks. Then usually after a year of age, the bladder is usually sufficient to accept a ureteral reimplant. You could always do another VCUG and get an estimate, do a cystogram and get an estimate of your bladder capacity that way. If you'd like to have an objective measure, but in most children, after a year of age, the bladder is usually sufficient to be able to handle a ureteral reimplant. Usually a Cohen, where you're going to tunnel going across the bladder transtrigonally, and not more like a Glenn Anderson, where you can actually just keep moving toward the bladder neck, usually not a sufficient distance there. But in most children, after a year of age, it usually is sufficient. But if you wanted to do an objective measure, you could do a cystogram and determine, what your bladder capacity was, but typically I don't do that. If a child is growing and developing normally, I've not had an issue, but I've only been doing this 12 years. I've not had an issue where I didn't, after I tapered the ureter, couldn't get a nice tunnel within the bladder.
Have you had sometime a situation where the implantation could not be done at the trigone and they are forced to do it at the bladder dome?
Where I've had to do it on the dome, where I couldn't do it on the trigone.
So how did you like it, or
well, there's so there's advocates for it, with kids that have these megaureters that they're the advocates of just plugging them in on the dome. I think that there was some papers written about that. I don't have any experience with that, not being able to get the ureter near the trigone. I've had to do different types of reimplants to be able to get a sufficient tunnel, and maybe moving the hiatus, like doing a polytunnel Ledbetter, where I do give the ureter a different hiatus so I can get the tunnel, but not where I've actually had to reimplant on the dome of the bladder. So in this situation, like the one kid where I had the short ureter, I elected to do a UU on that, but not had a situation where I've had to actually reimplant on the dome of the bladder. I can't say that I've had that experience. I've usually have been able to find a place that is and tunnel at least toward the trigone if I can't hit the trigone, but not where I've had to just plug the ureter in on the dome. I've not had that experience.
Mm-hmm.
I would imagine that would come if the child has had multiple operations, I would think, and you've had, and
Sure.
you've lost some ureteral length. I would think that would be.
I was thinking after you have had acutaneous ureterotomy, it might be difficult to get enough length, and also having transvesical track in a place that has been operated on before might be difficult.
Right, and I was going to say the redo cases are, but I've not had where I've had to leave it on the dome of the bladder, though I've not had that experience. But I've had to do some reimplants. I actually had a child that had a imbricated megaureter elsewhere that had to have febrile urinary tract infections. and I had to do a re-implant, and I ended up having to excise a lot of the imbricated ureter because it wasn't healthy, and doing an excisional taper. And, no, I didn't have to bring it in at the dome of the bladder, but I did mobilize the bladder some to free that up more, but ended up bringing it in, and you can tunnel toward the trigone, may not be able to hit the trigone, but being able to tunnel at least toward it and get a good tunnel enough that the reflux was resolved, and we got a good result. But sometimes it can be challenging with ureteral length, but a lot of these times, because to me, I find the ureter, it just almost seems to be endless though. So I guess I've been fortunate where I've had a lot of length, even in redos, because of the nature of the disease. It just tends to lend itself to a lot of redundant ureter, but I've not had to just plug it in on the dome. I've been able to just do different, whether it be a Peloton or Ledbetter, to bring it in a different hiatus that and tunnel that way, or to be able to get an anti-reflux and anastomosis, but not where I've had to just leave them on the dome.
Great.
All
I've
right.
been asking other questions. I hope my colleagues could also
Well,
say
I'm going to
something.
put my email here. I'm going to type it into the chat.
Mhm.
So just in case people are shy about asking questions, I'm available for questions anytime over email. How about that? Just in case, so that you guys can get a hold of me if you need to, if you have cases, and I'd like to be able to share cases. If you ever want to talk about cases, we can talk over email or even Zoom or whatever other. They have WhatsApp, they have all kinds of stuff nowadays. But here's my email. If you all need to get in touch with me, anybody has any questions they're shy about asking, we can, and I'll try my best to answer them. All right. Thank you all for your time this afternoon. It's morning here. It's a little bit after 9 o'clock. And so I'm about to start my office hours, but thank you so much, Katie, for putting all of this together. And I just hope to be able to do this again in the future, and we kind of develop this relationship so we can share cases and just bring pediatric urology to the world, and we just help a lot of children. So
Thank you very much, Regina. And we shall be keeping in touch and exchanging cases. And thank you for taking your time and giving a good presentation. And I'm sure my colleagues and I have enjoyed. Thank you very much.
I enjoyed you all. Thank you so much. And Katie, thank you. Take care.
Thank you.
Thank you.
Thank you. All right. Bye-bye.
Bye-bye.
Bye, and thank you for
Bye.
the email.
Thank you, Haley. Kathy, thank you very much. And this is a very good experience. And I hope we are going to be doing this kind of things together.
Yeah, let's do it. Yes, exactly. I got to get to Rwanda. Thank you so much. Thank you so much. Thank you again. Take care. Bye-bye.
Bye.
Bye.
Bye.